Chapter 38. 38 will cover thoracic trauma, or basically chest trauma. Again, in the trauma section, we don't see a lot different at the AEMT level than we do from the EMT level. There's a few things, a few new emergencies, or actually I guess new to you emergencies that we will cover here. But for the most part, again, we're looking at preventative, or not preventative, but supportive care and continuing to support the ABCs. As with all the chapters, if you have not read and studied the chapters yourself, do so at your earliest convenience. Simply watching and listening to the lectures is no replacement to actually studying on your own. We continue with the same topic of our standard as the AEMT applies fundamental knowledge to provide basic and selected advanced emergency care and transportation based on the assessment findings for an acutely injured patient. You have a multimedia video on the pneumothorax, and we have a few objectives, not a whole lot, but a few objectives that are found on 856 and 857. So in introduction, the organs in the thoracic cavity are responsible for ventilation, respiration, and circulation. So really, the B and the C really are contained within the thoracic cavity. Some of the stimulus, on the other hand, is not, but we covered that in the previous chapter when we talked about the head trauma. Injury to the thoracic cavity and to the content can quickly lead to death from hypoxia and hypercarbia, as well as blood loss. And injury can occur on the anterior, lateral, or posterior thoracic surface. Impact or penetration can result into injury to the vital organs. So in blunt trauma, motor vehicle collisions, falls, assaults, and so on and so forth, is responsible for about 20 to 25% of all trauma deaths. And penetrating trauma from shootings and stabbings, flying debris from explosions. So it is our intent to recognize and treat thoracic injuries promptly and properly and address those problems with their breathing and their circulation. It goes with your case study. Okay, so briefly, a little A&P recap here. Within our chest cavity, we have, of course, the esophagus and the trachea, which come down from the mouth, or the pharynx. Obviously, they split into two completely separate sections there. The esophagus leading down along the spine, going through the diaphragm and leading to the stomach, and the trachea going down to the carina, splitting into the right and left sides to the lungs. Of course, we have the heart. The greater vessels are also found here, so the superior and inferior vena cava and the aorta, as well as a significant number of other associated arteries and veins, the pulmonary tree and so on. We have the ribs, the sternum, the spine, the clavicles, the scapula, all kind of help define the borders or the edges of the thoracic cavity. The bottom barrier or bottom border, I guess, would be the diaphragm, the main muscle of respiration. The lungs in each side there, and then in between the ribs would be the intercostal muscles. The mediastinum is the space between the lungs, or that right, basically sandwiched between the sternum and the spine and between both lungs. It contains the esophagus, trachea, greater vessels, and the heart. And so obviously, yes, the lungs are on either side. The organs within the thoracic cavity have a significant number of bony structures that help protect them. But with that also, those bony structures, if they're damaged, run the risk of causing damage to the soft tissues underneath them. So the lungs and ventilation, They provide the oxygen for cellular metabolism and they eliminate carbon dioxide. Ventilation, remember, is the process of moving air in and out, and respiration is the gas exchange. We have external respiration, which is oxygen and carbon dioxide exchanged across the membrane in the lungs, so CO2 out and oxygen into the blood. Internal respiration is at the end organ, so say if it's a big toe cell, the gases are exchanged, so carbon dioxide gets into the blood and oxygen gets off the blood. And then ventilation. Ventilation requires for us to do it spontaneously an intact brainstem, nerve pathways, an intact chest wall, pleura, lungs, and the diaphragm. So we have to have all those components to do it spontaneously. However, ventilation is one thing that we can provide to a patient and not have several of these other items in place. However, we cannot mandate that the patient be respirated, so we can't make the gases exchange. There's in the hospitals and some of the larger hospitals, they do have some machines that actually will do that, but not something we can do at EMS in the field or even in most of the hospitals. So remember, the thoracic cavity is lined with pleura. We have visceral and parietal pleura. Visceral on the lungs, parietal lines the inside of the cavity. The pleura acts as kind of a lubricated surface, so the lungs aren't scraping up against the chest wall. During inspiration, the diaphragm and the intercostal muscles between the ribs contract, and they increase the volume of thoracic cavity, raise the ribs up and out, and then on exhalation, everything just relaxes, goes back to its normal position, decreases that volume, and air is pushed out. The heart is located at the center of the chest, below the sternum. It's fairly well protected behind that sternum, and it's responsible for perfusing the body with the nutrients, the chemical messengers, oxygen-rich blood, and bringing the CO2 back to the lungs for elimination. And in order to sustain life, the heart must be able to pump adequate amounts of blood. Kind of skipping through this rather quickly because this all should be reviewed for us. Any injury to the heart can create a life-threatening condition. Remember, your heart is surrounded by a tough membrane called the pericardium, so there's this sac around the heart. It's kind of the bulletproof layer, if you will, although it's not bulletproof. The bulletproof vest, I guess. The vena cava, both inferior and superior, carry that deoxygenated venous blood back to the heart, dumps into the right side, and blood from the right ventricle is then circulated to the lungs via the pulmonary arteries. Once it's circulated through the lungs and gas exchange has taken place, it returns to the left side via the pulmonary veins, leaves the left side of the heart to be circulated through the systemic circulation through the aorta. So anything that impairs the motion of the chest wall, contact between the pleural layers, the integrity of the lung, the alveolar surface available for gas exchange, or pulmonary perfusion interferes with tissue oxygenation and elimination of carbon dioxide, can create a huge, huge problem because there's so many of these little components that have to be there in order for us to exchange gases and then, of course, move gases. Injuries to the thorax are typically classified as either open or closed. During our assessment, we're going to be inspecting, palpating, assessing the thorax on all sides, make sure not to overlook additional wounds. If we don't have a perfectly conscious patient who's able to give us chief complaints and answer our questions appropriately, we really got to make them naked. There are 3 areas of the body that will kill you and kill you quickly, and that's the head, the chest, and the abdomen. Not that other areas won't, but those are the ones that are the most common quick killers, and they're silent killers. They'll hide things from us. So we need to ensure that the airway remains open and patent. assist ventilations as necessary, and that may be easier said than done when we're talking about problems with the chest and its contents. Provide supplemental oxygen to maintain an SpO2 of at least 95%. If we can monitor end-tidal CO2, that's great, because monitoring end-tidal CO2 helps us to see just how well is that person perfusing. You can, of course, put the cardiac monitor on them, not that you can probably read it. Treat for shock as needed. Consider the need for immediate surgical intervention. These are those patients that we make that consideration. Yes, I'm 5 minutes from the local hospital, but I'm 20 minutes from the level 1 trauma center. I'm bypassing the local and going to the trauma center. And then transport the patient to the appropriate facility. So during our scene size-up, of course, we're going to ensure that the scene is safe prior to us entering it. Remember, a lot of things that have the potential to cause thoracic trauma have the potential to cause trauma to us. Shootings, stabbings, car crashes, and so on and so forth. Number of patients, call for additional resources, and ensure standard precautions. Consider the mechanism of injury and look for the potential to need to do C-spine immobilization. Form your general impression. If they're unresponsive, immediately check for a pulse. If no pulse, begin CPR. Ensure the patient has an adequate airway. Assist them, assess their breathing, assist with BVM as necessary, and then check for a pulse. That's if they are unresponsive, check for pulse, start CPR. If they have a pulse, of course, then, or they're alert, assess breathing, assist as necessary, so on and so forth. Control any significant bleeding. Remember, that's part of circulation. So as we're looking at circulation, we're looking at skin, we're looking at bleeding, we're looking at pulse. Oxygen to keep the patient's SpO2 at 95 or better. Rapidly extricate our critical trauma patients from vehicles. Make decisions about the need and feasibility of ALS response and air medical transport. Perform your rapid trauma assessment, exposing the patient, checking their head, neck, chest, abdomen, pelvis, extremities for potentially life-threatening injuries, quickly palpating and auscultating the chest, and checking for injury and equality of breath sounds. Immediately cover any open injury in the neck or chest, because those have the potential to suck air in, either causing an embolus or creating a potential pneumothorax. And do not forget that the back is part of the chest. Just because the opening is next to the scapula doesn't mean that that doesn't affect the chest. It certainly does. Even though we don't see it as often, it's every bit as important as a hole in the front of the chest. So some signs of chest trauma to look out for: cyanosis, tachypnea, dyspnea, soft tissue injury to the thorax, penetrating trauma to the thorax with or without the presence of a sucking chest wound, decreased or absent breath sounds in the lung fields, paradoxical movement of the chest. This is when part of the chest wall moves in opposition to what it normally should. So we know that most people who suffer or who are breathing, when they inhale, their chest goes up and out. When they exhale, it goes in and down. With the patient with paradoxical movement, that section of ribs, the flail segment, as we refer to it, the flail segment actually moves in the opposite direction. So as we inhale, while the rest of the chest is going up and out, the flail segment is going in and down, and then vice versa. When we exhale, most of the chest is going in and down, where the flail segment is going up and out. And so that is paradoxical movement. Hemoptysis or bloody sputum, subcutaneous emphysema, which is the air bubbles underneath the Skin, usually in the neck, the jaw, and the upper chest, caused from a leak in the airway system. JVD, tracheal deviation, both of those are fairly critical. Can be tracheal deviation is a very late sign, and signs of shock. All right, our secondary assessment is going to include vitals, monitoring devices, history, physical exam. Don't forget to get a full baseline vitals. Perform an appropriate head-to-toe or focused assessment. Treat your life-threatening injuries as you find them. Critical patients will get the history and the rest of the exam en route. If they're unconscious, don't forget to look for things like medic ID bracelets. Look for medications. Look for other clues around the scene. And then don't forget to communicate and document. Serious thoracic injuries require immediate evaluation and intervention. The sooner you can give a trauma alert to somebody, the better. They can get staff on the way in. If you got any specific orders from medical control, document those. Include what's pertinent so that preparations can be made so they can get the appropriate staff coming in, and record your details on your PCR. In reassessment, anticipate the potential for developing problems with ventilation and perfusion. Reassess every 5 or 15 depending on the patient's condition, and watch for signs of deterioration. All right, so some types of thoracic injuries. Here we have an example of a penetrating trauma to the anterior chest. Probably a pretty gosh darn good chance that there is a heart injury involved there. Might be just a little above it, but I'd say if it was downward aiming at all, there's probably a pretty good chance that the heart was affected. So with open chest injuries, either penetrating or blunt trauma to the thorax in which the integrity of the thoracic wall is broken, we're going to identify the mechanism, generally looking for entrance and exit wounds. In most cases, this is not going to be a blunt trauma unless it was a severe crushing injury that caused it to blow out. More times than not, it will be some sort of a penetrating trauma, a bullet, a knife, an arrow, some sort of a missile, all kinds of things could potentially cause this penetrating trauma. Just because there is an entrance does not mean there is an exit, but in many cases there is. If we're talking about a shorter knife, of course, there's only going to be one wound. But if we're talking about a .45 caliber handgun, there's probably going to be one little entrance wound and one pretty good, gosh darn good size exit wound. So injuries to the trachea, esophagus, diaphragm, heart, and greater vessels. These people will usually deteriorate extremely rapidly and will generally result in an exsanguination or hypoxia. Going to go very, very, very bad very, very quickly, getting those things there in the mediastinum. Pneumothorax is not always quite as quick, but it is definitely a killer. Pneumothorax is when we have air accumulating in the pleural space, so between the parietal and the visceral pleura. Air is now filling that space. There should not be anything in that space except for a little bit of pleural fluid that acts as a lubricant. So as air starts to fill that up, it actually takes away some of that surface tension, and it allows that lung to start to collapse. Now, if they have an open pneumothorax, we call that a sucking chest wound because it makes that sound as air goes in and out through those tissues. It's kind of the slurping sound. So it'll suck air in through the chest wall and then blow air out sometimes. Sometimes it will blow air out through the chest wall. In most cases, it's on the inspiration. So you may see bubbles of blood as air escapes through the wound. In the cases of closed chest injury, it's usually as a result of blunt trauma. Again, you're going to need to look at their mechanism of injury. They may have broken bones. In many cases, they will have broken bones, and that'll be the major sign that we see. Don't forget those broken bones as they move, because that chest, those ribs and sternum move every time you breathe. So it can penetrate or lacerate some of your internal organs, including your liver, your spleen, your stomach, which would be in your abdomen, but your lungs, your heart, your greater vessels, so on and so forth. So if a patient gets struck in the ribs with a baseball bat, the impact does not result in penetration of the tissues. However, a rib was fractured and driven into the liver. What impact can this possibly have on us? Well, we know that the liver is extremely vascular, so there's that high potential for there to be severe bleeding. So with rib fractures, can be from blunt or penetrating trauma. People get shot in the rib all the time and bust off a rib. It can cause internal bleeding. Remember, under every rib there is a artery, a vein, and a nerve. So there's a neurovascular bundle under each rib. There's the potential for some pretty good bleeding. They're going to have some severe pain, probably, hypoxia, potential lung injuries. That increases the mortality rate of thoracic trauma, patient, because not only is there the potential for there to be that immediate injury, but with that pain, they tend to hypoventilate. When they get hypoventilating, they're hypoxic. That can lead to immediate problems, or down the road, because they don't want to breathe heavy because of the pain in the rib, they develop those infections, and there's a certain number of fatalities that occur from that. So signs or symptoms of a rib fracture on 863, you'll see that pain or tenderness, contusions, open wounds, crepitus, guarding, where they're trying to hold their chest so it's not moving much, pain on inspiration, hypoventilation, hypoxia, hypercarbia. We have really no definitive treatment in the pre-hospital environment for for rib fractures. Our biggest thing is to maintain ABCs and allow the patient to sit in a position of comfort. We need to probably concentrate on making sure their ventilation goes well. If they're satting low, their CO2 is high, we're going to want to either encourage the patient to breathe deeply or have to breathe for them and assist ventilations with a bag valve mask. We probably should not be giving this patient nitrous oxide because of the potential for the pneumothorax. So this might be somebody we would consider having paramedics come for a little analgesia. They can also splint this by holding their hand over the site, or sometimes we'll give them a pillow to just kind of hug. And by holding that pillow, it doesn't put a lot of direct pressure on it, but it gives it enough extra support that it doesn't freely move and cause a lot of excessive discomfort. But we don't band the chest, we don't put any sandbags on it, we don't tape it or anything. It's really geared towards maintaining appropriate ventilations. Consider starting an IV. All right, paradoxical movement of a flail segment. Remember, a flail segment is two or more consecutive ribs broken in two or more places. So, I mean, if you have rib number 1 and rib number 7 fractured, that's not going to be a flail segment. But if you've got, like in this case, 5, 6, and 7 are all fractured consecutively in the same area, then you're going to have a flail segment, which is going to be evidenced by paradoxical movement, like I mentioned, that it moves in opposition to what the chest normally does. So that segment kind of floats. This is a fairly life-threatening incident or injury because the whole physiologic process of ventilation is disrupted. They lose a significant amount of their billows or their negative pressure pump, I guess, if you will, to move air in and out. So it's going to generally lead to some hypoxia. Very possible it will also lead to a pulmonary contusion. So they may start to get some blood accumulating there in those lung tissues. Makes it much more difficult for air to obviously get through the alveoli. Shows an example of pulmonary contusion there where we've got a little bit of blood leak into those tissues, and it's more or less causing kind of a similar process as does congestive heart failure. So the pulmonary contusion, it's the inability of the lung tissue to appropriately exchange gases. And our signs and symptoms of a flail segment, same as those of the ribs. Pain or tenderness, dyspnea, contusion, crepitus, guarding, pain on inspiration, hypoxia, hypercarbia, but we add paradoxical movement. It may not always be incredibly obvious, but and then emergency management of it. We could consider some CPAP here. However, we got to be cautious because if we have a patient with a pneumothorax, we make that much worse. So CPAP would probably be, you'd have to be very, very confident that you did not have a patient with a pneumo. Ventilation could, assisting ventilation might be also another option. And you could, again, give them a pillow to hug. Pneumos. We have three major categories of pneumos. We have simple, we have open, we have tension. We may also have spontaneous, which we've talked about before. Spontaneous is one that doesn't occur as a result of trauma, but most commonly in the COPDers or the tall, thin males. But a simple pneumothorax, there's just a little bit of air closed in the pleural space. There's actually a significant number of people that walk around with a simple pneumothorax. They don't even realize it. They have kind of a sore shoulder for a couple of weeks after a trauma or a surgery or something's happened, and their shoulder just is sore, and it's more of an annoyance than anything. They may go in and finally get checked. They do a chest x-ray and find out, oh, what the heck, you know, you got 30 or 50 cc's of air trapped up there. And usually they're kind of self-limiting. Open pneumothorax, on the other hand, this is going to lead to generally not a very good outcome. So this open chest wound allows air from the outside to get sucked in. It's easier for air to pass through the chest wall than it is to go in through the mouth and nose, down through the pharynx, to the trachea, to the carina, split, and so on and so forth. It's easier for air to fill that space just going through, 2 inches of chest. So, and so it gets in there and it impedes the lungs from expanding. And then, of course, we have the tension pneumothorax. It's not terribly common. It does cause an immediate life threat. We have air accumulating at a fairly rapid pace between the pleura. It cannot escape because there's not an open hole, and it's trapped in there. And it just continues to build pressure, build pressure, build pressure, and it eventually puts so much pressure on the affected lung that eventually it starts to shift over to the heart, the mediastinum, and the unaffected lung. You may see some tracheal deviation with a pneumothorax and a mediastinal shift. It is not common to see it. It is a late sign. Do not rely on tracheal deviation to suspect a tension pneumo. If you have a patient who has decreased or absent lung sounds on one side, maybe some JVD, signs of shock, and difficulty breathing, you probably should strongly suspect tension pneumo. Tension pneumo can occur with either an open or a closed thoracic injury. Most of the time, if you have an open pneumo, if you get a patient that will build up attention, it may be actually because of your treatment. Remember when we taught you about occlusive dressings, that occlusive dressing, if you apply it and tape it down on all four sides completely, air cannot escape. The intent of the occlusive dressing is to keep air from getting back in, but we also need to have a valve for air to escape as necessary. So if we tape it completely on four sides, there's no air escape. There's a video on pneumos. So signs and symptoms of a pneumo, you'll see on 865. Tachypnea, diminished or absent breath sounds on the affected side, tachycardia, hypoxia, JVD, cyanosis, subcutaneous emphysema, not always. Unequal chest expansion, not always evident. Extreme anxiety, usually is evident. Increased resistance to positive pressure ventilation is very possible. Tracheal deviation, a very late sign. Signs or symptoms of shock lead you to believe tension pneumothorax. And then worsening condition despite our treatment. This talks about occlusive dressing. Tape it on three sides, or there are other schools of thought that say you leave one corner untaped. Either way, just as long as we get it taped down so air cannot easily get in, but yet there's a way for air to escape as needed. There are also some things called chest seals. Asherman's chest seal is one that comes to mind. Sam Company has one, but they're kind of like big. They look like big EKG electrodes, basically, that you slap on over the top of them. The Asherman chest seal has a whoopee cushion valve in it, so it looks kind of like a weird whoopee cushion. But they allow air to escape. They don't allow air in. The pneumothorax, we want to prevent this condition from getting to a pneumo, or from a tension pneumo. If we have a sucking chest wound, immediately cover it with your gloved hand to prevent air from entering, and then apply the occlusive dressing. Remember, with your occlusive dressing, if you're buying commercial occlusive dressings, it's usually a Vaseline impregnated gauze in a foil wrapper. Have you ever tried to tape anything to Vaseline? Okay, so don't rip open the package and throw it off to the side and then expect to take this Vaseline gauze and slap it right on their chest and tape it down. It's not going to work. Take it out of the package carefully, lay it over the top of the sucking chest wound, and then take the packaging itself and put it over the top of the gauze and tape it down. Some people don't think about that, and it's not something we do very often, but we got to have something there to prevent air from passing through and a way to secure it. So hemothorax. This is the accumulation of blood in the pleural space. It's like a pneumo, except instead of air, there's blood there. The management is really the same as that of a pneumo. Usually it's going to lead us to ventilation. Definitely no CPAP for pneumo patients, no CPAP for hemo patients. Attention hemo can occur as well. We can have a pneumohemo where we have both air and blood accumulating in there. So there's all kinds of interesting, fun combinations we can get there. Traumatic asphyxia. Traumatic asphyxia is the sudden massive compression to the chest. And you will see this guy has all kinds of petechial hemorrhages right up there in his face, almost this purple tone to it. It's almost from like that crease in his chin. You can see that there's a line of demarcation there where he's got definitely some difference in skin tone there. So we have this massive compression. The patient appears to be asphyxiated, although the asphyxiation did not actually occur. And they'll have that bluish-purple discoloration in the upper chest, the neck, the head, and then we usually will also have JVD, conjunctival hemorrhage, or basically the whites of their eyes turn red from the blood vessels bursting. Edema of their tongue and lips, look like a patient with anaphylaxis. So thoracic trauma in pediatric patients also should consider the possibility of an abdominal trauma because things are so close. And the increased flexibility of the rib cage makes the internal organs more susceptible to injury and may not have as many outward signs. Blunt cardiac trauma, so impact with the sternum, being compressed between the sternum and the spine. The heart can sustain a contusion, so it will cause a bruise on the heart muscle itself. That can lead to decreased cardiac output and shock. May also cause some vessels to rupture, and as vessels rupture, you run the risk of one of the next things we'll talk about, which is pericardial tamponade. They may develop chest pain. They may look like they're going into heart failure or cardiogenic shock. They can have cardiac arrhythmias. They can go into cardiac arrest. The thing to keep in mind about people who go into cardiac arrest from trauma, 0.5% survive. Once a person arrests as a result of trauma, it is not usually a good outcome. Commotio cordis. Commotio cordis, this is a sudden cardiac arrest resulting from a sudden blow to the center of the chest. So once in a while you hear about a pitcher in baseball, he throws one down the alley there, the batter hits it, line drives it right back to the pitcher, hits the pitcher right in the chest, and the pitcher drops over dead. And that's a commotio cordis. Basically what happens is the impact occurs at just the perfect wrong time in the cardiac cycle because the heart has its depolarization and repolarization. And there's a certain part of the repolarization which the heart cannot depolarize. But if it gets hit, if it takes an impact, it does depolarize. And that depolarization just knocks everything out of whack and puts them into cardiac arrest. Martial arts, baseball, some other sports that may be more common to see in. But it's just the exact wrong part of the cardiac cycle. And pericardial tamponade. Pericardial tamponade is when pressure builds up between the pericardial sac and the heart itself. Remember, we have that tough outer sac, that bulletproof vest around the heart, and blood or another fluid, in the cases of trauma, it's almost always blood, is leaking inside there. And what it does is then causes blood to continue to fill that sac. The sac will only stretch so far, and then it starts to put pressure back in on top of the heart. The signs or symptoms that go commonly with pericardial tamponade is called Beck's triad. So we had Cushing's for the head and Beck's for the heart, where they will have hypotension, distended neck veins, and muffled heart sounds, which you're not going to typically listen to heart sounds, so that one could be hard. But hypotension and distended neck veins in the presence of chest trauma, be thinking could be pericardial tamponade. Sadly, there's not much we can do for that. Get them to the hospital where they can hopefully drain some of that off of there. All right, so when thoracic trauma presents, pay close attention to the mechanism and the patient's signs and symptoms. Because the organs and the vessels contained within the thoracic cavity are vital to sustaining life, maintain a high index of suspicion of an underlying injury. When life-threatening injuries to the thorax exist, act immediately to prevent deterioration in the patient's condition. And assessment skills and knowledge of the appropriate treatment will help reduce morbidity and mortality.